Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, I'd like to welcome you to today's webinar entitled Effective Intake and Assessment of Pregnant and Parenting Women. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your own name. If you have questions, please send them to the presenter and me, I'm the host, using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them throughout the presentation today. The presenter will answer questions at the end of today's webinar. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. But if you experience poor computer audio, there are a few options to try on screen right now, and I've also posted these instructions or tips in the chat box already. If you continue to experience a loss of audio or poor audio through your computer, you can rejoin the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 5 business days. We also will be sharing a PDF version of this PowerPoint presentation. We'll be sharing that via email also within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FATA website. If you would like to receive continuing education credits or a certificate of attendance for this event, you must complete the evaluation. And please be sure to include any Florida license number as applicable for reporting to CE Broker, along with the prefix for your license number. And again, the certificates of attendance will be delivered to your email address within 5 business days for all attendees. Note, please, that WebEx does monitor arrival and departure of attendees and provides a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We're not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. All that being said, I'd like to go ahead now and introduce today's presenter. Amy Petty-Falin is the Addiction Services Coordinator and Intensive Outpatient Substance Abuse Therapist at Chautauqua Healthcare Services. Ms. Falin specializes in assessment and treatment of substance use disorders among women who are pregnant or involved with child welfare. Previously, she served as the Family Care Assessor at Chautauqua Healthcare Services, conducting mental health and substance abuse evaluations on families involved with child welfare. Ms. Falin also provided case consultation with child protective investigators and family services counselors. Amy holds a Master's of Arts in Clinical Psychology from Middle Tennessee State University. And we're very pleased to have Amy join us today. And Amy, if you're ready, I'm going to go ahead and pull up the presentation for you. Are you ready?
Yes, ma'am. Thank you.
Wonderful, and welcome. And Amy, when you're ready, you can go ahead and let me switch control over to you. And when you're ready, Amy, you can click inside of the PowerPoint pane and begin navigating when you're ready.
Okay, thank you, Leanne. I appreciate it. Thank you all for attending this webinar today. I do want to give a warm thank you to the Florida Alcohol and Drug Abuse Association, as well as the Office of Substance Abuse and Mental Health with Department of Children and Families for giving me the opportunity to share this information with everyone today. My aim is that everyone attending this webinar today will be able to take the information that is discussed and use it in some way that will help the families and women that we serve. Before we begin, I do want to inform everyone that is attending that the case illustrations and examples that are being presented are fictitious and represent a composite or an overview of a number of cases that were reviewed. Information regarding the case illustrations has been changed and does not represent a specific case or an individual that has been served. So with that being said, we'll go ahead and get started. Okay, so we have three objectives that will be discussed today. The first objective is we're going to explore common themes or characteristics among pregnant and parenting women with substance use disorders and how these factors can be utilized during the assessment process. The second objective will be how to use and implement a strengths-based, client-centered approach while assessing pregnant and parenting women with substance abuse problems. And then the third objective will be how to use assessment and intake methods for pregnant and parenting women with substance use disorders that allow their treatment plans to effectively address their stresses, traumas, concerns, and goals. So our first objective is identifying common themes or characteristics among pregnant and parenting women with substance use disorders and how these characteristics can be used during the assessment. So first I want to start by saying that there is no single pathway for addiction or the development of a substance use disorder, and that there are multiple pathways from substance use initiation to dependence that determine the development of a moderate or severe substance use disorder, meaning that there is no specific biopsychosocial characteristic that is solely responsible for the development of a substance use disorder. Although there are multiple pathways from substance use initiation to dependence, a history of trauma or exposure to trauma is one of the common factors among women with substance use disorders. With this in mind, today we will be discussing trauma and various aspects of trauma that relate specifically to substance use and the development of a substance use disorder. In this discussion, I do want to be clear that although many factors may be related to the development of a substance use disorder, please keep in mind that the primary focus will be on the connection between trauma and substance use among women who are pregnant and parenting. So for the purpose of the discussion, 5 common themes have been identified and each will be discussed in depth. The first is exposure to traumatic events such as physical and sexual victimization and exposure to interpersonal violence are more likely experienced by women with substance use disorders. Relationships within the context of the family of origin and early family exposure to substance use have been found to be closely associated with women's initiation to and development of substance use disorders. Consideration must also be given to the caregiver role and responsibility that women often assume. Societal attitudes towards women substance users also must be taken into consideration. And telescoping. A rapid progression from initiation of alcohol use to rapid progression into a severe substance use disorder is more common among women with substance use disorders. So each of these things, we're going to discuss them in depth. So we'll go ahead and get started with the first theme. So exposure to traumatic events such as physical and sexual victimization, as well as exposure to interpersonal violence is more likely among women with substance use disorders. Use and abuse of substances may be a method to self-medicate symptoms associated with trauma or other co-occurring disorders. As a result, substance use may serve as a method to cope and experience positive feelings, which reinforces the effects of substance use and behavior. So in regards to exposure to traumatic events, the research suggests several things. First is that women abused as children are not likely to report substance use. Are more likely to report substance abuse. So again, let me reiterate that women abused as children are more likely to report substance abuse. According to Najavides, childhood physical or sexual abuse is the most common form of trauma among women receiving substance abuse treatment. Compared to men, rates of PTSD among women in addiction treatment are almost doubled, 33% compared to 59% respectively. During periods of substance use and intoxication, women are placed at a greater risk of additional trauma and victimization. As a result, trauma serves as both a risk factor and a consequence associated with substance use. Use and abuse, as mentioned previously, use and abuse of substances may be a method to self-medicate symptoms associated with trauma or other co-occurring disorders. As a result, substance use may serve as a method to cope and experience positive feelings, which reinforces the effects of substance use and behavior. Admitting or verbalizing the extent or severity of substance use may be fear-provoking, especially when these women have few coping strategies and limited social support. Using substances may be the only form of relief from emotional pain. Without substances or adaptive coping strategies, complete abstinence from substances may seem too overwhelming or impossible. Therefore, discussing the severity or extent of substance use as well as the thought of complete abstinence may be very, very difficult for the individuals during the assessment process. It may be too overwhelming or may even feel, abstinence may even feel impossible to the woman. So as a result, it's important for us as clinicians to recognize minimization or denial associated with self-reported substance use. And recognizing that is not something that, it's not uncommon during the assessment phase and may be a form of coping for the woman. So although a woman presenting for substance abuse treatment may not present with symptoms of PTSD, it is important for clinicians to be aware that these women are likely trauma survivors. So even though the individual may not present initially with symptoms of PTSD, or that they may not even meet the threshold for a diagnosis or DSM-5 diagnosis of PTSD. So it's important to keep that in mind during the assessment phase, that they may not meet diagnostic criteria for a PTSD-related disorder. Also, a history of violence within the family is also a significant risk factor associated with substance use among women. So theme number 2, relationships within the context of the family of origin also have been found to be closely associated with initiation and development of a substance use disorder, beginning with early family exposure to substance use. Substance use, it has a significant impact on the family as a whole and interferes with the caregiver's ability to provide a consistent and nurturing environment for children. In order for a child to meet developmental milestones, thrive and function adaptively, children require an environment that is safe, stable, consistent, and nurturing. Environments where substance use is occurring and is occurring frequently is often the exact opposite of an environment that most children need. These environments where substance use is taking place are often chaotic, unstable, and inconsistent. This does place the child at an increased risk for harm and danger. It's also, like I had mentioned before, it's also the exact opposite of an environment that the child needs to thrive in. Also, SAMHSA, the Substance Abuse Mental Health Services Administration, indicates that women who were tasked with over-responsibility as children or taking on adult responsibilities as children, such as parenting younger siblings or providing emotional support to their own parents, are more likely to initiate drug and alcohol use. And then also, on the other hand, parental warmth within the family of origin can also serve as a protective factor from initiation of use, abuse, and dependence to drugs and alcohol. A family history of substance use and genetic vulnerability is a significant factor related to the development of a substance use disorder among women. It is important to note that genetic and environmental factors within the family of origin are likely interconnected. For instance, genetic vulnerability to developing a substance-related disorder may help predict the development of a substance-related disorder. However, if a parent has a substance use disorder and uses substances to cope with problems, the use and abuse of such substances are normalized within the context of the family. Consequently, the behavior is perceived as acceptable within the family. Also, women are more likely to be introduced to drugs and alcohol through partners, spouses, and family members. Additionally, women also are more likely to have partners who use substances. According to Najavides, women tend to model their partners or significant others' addiction patterns. Women have less support from spouses, significant others, and family members when they are seeking and receiving substance abuse treatment. As a result, women are more likely to relapse in the presence of a partner or a significant other. So the third theme is consideration must be given to the caregiver role and responsibilities that women often assume. Women seeking and engaging in substance abuse treatment may be influenced by their caregiver role. In assuming the caregiver role, these women may be caring for family members other than children. Women in caregiver roles may be unable to attend treatment due to the demands of caregiving. They may also lack support and encouragement from family members or partners to engage in treatment. And then the fourth theme is societal attitudes towards women with substance use disorders also should be taken into consideration. Women who are pregnant and have children may be fearful of the consequences, whether those consequences be legal involvement, child welfare involvement. Women who are pregnant or have children, they are fearful of those consequences and the possible stigma that is associated with having a substance use disorder. And Natavides, she indicates that women are judged more harshly for addiction than for men. As a result, women may present for treatment or the assessment denying the extent of their substance use and or involvement due to their fears of either being judged harshly or critically, or the fear of the consequences for discussing the substance use. The telescoping, this is the rapid progression from initiation of alcohol use to rapid progression into a severe substance use disorder. This is more common among women with substance use disorders. Although women may start drinking, or when women start drinking, they may initially drink less than men, but they progress much more quickly into a severe alcohol use disorder, meaning it takes fewer years for women to go from first use or initiation to problematic use or dependence of a substance. As we move through this webinar and begin discussing the assessment process, I would like everyone to keep in mind the 5 common themes that we have discussed, because we will be periodically referring back and reflecting back to these themes. These themes are not only areas that will need to be examined during the assessment, but these are also likely to be factors that will also need to be addressed during treatment. So in regards to the themes discussed so far, you're probably asking yourself why or how is this information important and how does it relate to the assessment process? So as mentioned previously, there are multiple pathways into the cycle of addiction, and I think that is important to note that and recognize that. Substance use, it impacts multiple areas of the woman's life, to include emotional, cognitive, interpersonal, and family functioning. Substance use rarely occurs in isolation and is often a response to multiple factors occurring within the woman's life. And being aware of these common things that we just discussed, it assists us as clinicians in understanding the complexity and challenges associated with assessing and treating this population. It also provides us as clinicians with a framework of what to evaluate and examine during the assessment process. When we are better able to evaluate and examine these factors in depth, we are able to provide more effective treatment with better outcomes. Improving treatment outcomes also is related to improving overall treatment retention rates. So another area that should be taken into consideration as it relates to specifically treatment outcomes is improving the overall treatment retention rate. This begins with effectively identifying what treatments are effective and service delivery. How are the services going to be offered? So most importantly, Najavides, in 2002, her research concluded that individuals with reported multiple substance abuse treatment episodes were never asked about trauma. Likewise, some mental health professionals also fail to assess for substance use or abuse. In order to effectively treat women with substance use disorders, a thorough assessment is key. It lays the foundation for treatment. So how to use and implement a strengths-based, client-centered approach while assessing pregnant and parenting women with substance abuse problems. So a strengths-based assessment is a goal-oriented and it focuses on the individual's unique talents, assets, resources, and skills as a way of overcoming challenges or barriers associated with meeting goals. Focusing on the individual's strengths and encouraging her to utilize those strengths increases her self-efficacy and confidence in her ability to identify and resolve problems. As a result, the therapeutic relationship needs to be collaborative and supportive. A strengths-based assessment and client-centered approach considers and focuses on identifying the woman's perception of the problem and the goals that she wants to accomplish. This approach provides treatment recommendations and resources that meet the individual's needs and goals. And also, I want to reiterate that a strengths-based approach, it moves away from focusing only on the problem and moves towards focusing more on the woman's strengths and as well as her own perception, how she perceives the problem and what she wants to accomplish or what she wants to gain from treatment. So family care assessment or family care unit, an effective model that can be used to thoroughly assess the complex needs of women with substance use disorders and their families. So in Walton County, which is where I'm located at, it's also Circuit 1. We have a specialized unit, and it was referred to as the family care unit. It was responsible for completing assessments for families involved with child welfare. And in discussing this model, I want to be sure to be clear that this model, it can be adapted for all women with substance use disorders, not just women involved in dependency cases. So what the model is, it uses a strengths-based, client-centered, and multidisciplinary team approach to the assessment process for families at risk and families involved with child welfare services. The family care assessment or the family care unit provides comprehensive mental health and substance use evaluations to individuals involved with the child welfare system or Department of Children and Families. It also links women involved in judicial and non-judicial dependency cases to the appropriate treatment services. Again, this model, it can be adapted for all women with substance use disorders. It is not limited to only dependency cases. So in non-judicial cases, the aim of the family care assessment or the family care unit was to link and engage the individual in treatment and services to prevent removal and dependency. On the other hand, in judicial cases where there was dependency and dependency court was involved, the family care assessment, the recommendations that came from that assessment served as a major component in the case plan to support the reunification process. So whatever treatment recommendations we made in the family care assessment, that essentially went into the DCF or the FFN case plan. I'm sorry, I got carried away. So because these assessments are directly related to child welfare, it is crucial to assess the women that we receive referrals on thoroughly to ensure that treatment programming supports specific needs. Also, I want to keep in mind that the family care assessment, because they involved dependency cases, the safety and well-being of children are also involved, and those types of things are taken into consideration during that process. So because there is the child safety component there as well, a thorough assessment is critical. But again, I do want to reiterate that the family care unit, or the model that we used, is not specific to women that are just involved with dependency cases. It can be used with any individual woman that has a substance use disorder. So here are some of the key components of the family care unit. First of all, a multidisciplinary team approach. What was used, it included weekly staffings or case consultations. These meetings or weekly staffings included child protective investigators, family services counselors, family support team services, family preservation counselors, the domestic violence victim advocate, as well as the WISE program, which was substance abuse case management services. So it was a pretty big team with a lot of people from different areas and multiple disciplines. So again, there were multiple service providers involved in the process. The team-based approach was very, very helpful and continues to be helpful in providing care continuity and linking individuals into a number of services. It also reduces the potential for possible conflicting goals across systems of care. So sometimes the goals of the child protective investigator may not always meet the goals of treatment. So that kind of reduced some of that. So here are some more key components of the family care unit. High-risk families who are at risk for dependency were referred to what we referred to as clinical response team. The team is facilitated and was organized by the family care unit. The team's purpose is to collaborate with the family and to determine what issues need to be examined and addressed, and how these issues can be addressed while keeping the children safe and in the home. This also provides women with substance use disorders. It allows them access to multiple resources and service providers who can assist them in meeting their needs. So although the family care assessment directly focused on families involved with child welfare, again, using a team-based approach should be used in treating women with substance use disorders. It shouldn't be limited to just women involved in non-judicial or dependency cases. So a team-based, again, I've just mentioned this, that a team-based approach is recommended for women with substance use disorders. This approach is not limited to dependency cases. And then also something else that was pretty unique, or what I found to be pretty unique about the family care assessment, especially family care assessments where individuals were involved with clinical response team, an assessment was completed within 72 hours, or it was recommended that the assessment be completed within 72 hours of the referral. So collaboration and coordination across service delivery systems, providing care continuity and reducing the potential for conflicting objectives across service providers and providing optimal support and care for the complex needs of these families. That was another key component associated with the family care unit. Also, building a strong therapeutic alliance with the woman and providing her with the opportunity to engage with multiple service providers to get her needs met, build trust, and to provide her with hope. So you're probably asking yourself, how do you implement or use a multidisciplinary approach that is comparable to what we did as the family care unit? My first suggestion is that if you don't have something like this already set up or in place, begin by making a simple phone call to the referral source. If a referral is not submitted, request that the client sign a release of information for various service providers or various providers that are going to be involved with the client throughout the treatment process. Collaboration in a team-based approach can start with a simple phone call to another agency, and it can also result in doing a warm handoff when linking that client to another provider to get a specific need that can't be met, assisting them in getting that need met. Also, ask the client about meeting with all parties involved. Include the client in the process. I think that that's probably one of the most important things, is including the individual being served in the process. So the process of family care assessment and evaluating parenting and pregnant women. This is what I do before the assessment. I do a comprehensive case file review. It is conducted on the woman to include review of information provided within the Florida Safe Families Network, also known as FSFN. So I do a case file review of that database on that specific individual or family. A case file review is also conducted internally within our agency to examine the woman's behavioral health, substance abuse, and if she has previously received services through our agency, getting an idea of what her treatment history looks like. It is recommended that a case file review be completed for all women with substance use disorders. Although the cases that I was involved in were directly related to dependency or related to child welfare, it is recommended that a thorough case file review be completed among all women with substance use disorders, regardless of whether they are involved with child welfare or dependency court. Some may argue that the information that we review during the case file review, they may argue that access to this information could result in preconceived notions or biases about the individual that is to be assessed. However, SAMHSA recommends using multiple sources of information to obtain a broad perspective of the individual's history and how the information relates to her current presenting problem. This method also provides clues into her degree of impairment, functioning, and distress. It helps the clinician notice patterns of behavior that may be directly related to the presenting problem. Therefore, I highly recommend, I highly suggest doing case file reviews before you meet with your client. Review of information obtained through the referral and contacting the referral source to gather additional information regarding the reason of referral is also recommended. So you're probably asking why or how is information related to a case file review, how is that helpful during the assessment process? One of the things is that the background information related to the woman's history is helpful, especially as it relates to substance use and trauma. In substance use, denial and minimization, as we've discussed before, the denial and minimization associated with the severity and extent and nature of actual substance use is common, especially when a woman feels guilt or shame about her use. So it's not, like I had mentioned before, it's not particularly uncommon for you to see that minimization or the denial associated with discussing substance use. With trauma, secrecy, embarrassment, guilt, and shame may prevent the individual or the woman from wanting to disclose. So with that in mind, review of information, especially the information that is provided in FISBIN, that may reveal that the individual that you're serving, was a child victim, which is an indicator that the client has likely experienced or been exposed to some form of trauma, abuse, or neglect. Secondly, the information may reveal a parental or family history of abuse and neglect directly related to substance use, which is another common theme that was previously discussed. And then also, reviewing the case file, it also provides me the opportunity to explore her history and involvement with child welfare in greater depth, and to determine whether there are similar patterns, of behavior that exist. It also gives me a better understanding of the complexity and nature of the problem. For some, generational abuse and neglect within families is not uncommon, and is something that needs to be explored and addressed during treatment. So regardless of the information that you have available, you must be willing to respect and understand that a woman may not be willing to disclose this information, especially as it relates to trauma and substance abuse, especially during the initial interview. It is not appropriate or ethical to force her to talk about information that you gathered during the case file review. In my experience, again, I've mentioned this before, in my experience, the information that is gathered during the case file review is very, very helpful in understanding the complexity and nature of the presenting problem or what needs to be treated and further evaluated or assessed. So during the assessment, it's important that as women disclose information to you, it's important for you to be aware of how you're responding or reacting to the individual. How are you interacting and responding to them as they disclose pertinent information to you? So what I'm going to do is I want to share a case with you, and as I'm sharing this case, I want you to explore kind of your own emotions, thoughts, and reactions. I want you to ask yourself, what am I thinking, what am I feeling, and how am I reacting? I also want to disclose that the case that I'm going to share with you may be extremely difficult for some of you to hear because it does involve physical injury to a child, and it will likely provoke some pretty significant emotional responses. But again, I want you to be aware of how you're reacting, how you're responding, and how you're feeling. So before we begin, I want to clarify that the mother to these children was in a relationship with a man who was not the biological or adoptive father to the child that's discussed. In the summary, or what I'm about to share with you, the boyfriend or the paramour is referred to as John, and mom is referred to as Jane. So I'm going to go ahead and get started with that. Based on reports provided by DCF, verified findings of bizarre punishment, unexplained physical injury, medical neglect, and substance use were indicated and eventually substantiated. Based on information provided through the family functioning assessment, John admitted to pouring a bucket of water on Jane's 5-year-old son to prevent the child from napping. Jane's 5-year-old son reported that John will tie his ankles to the bedpost. Further investigation indicated that the mother was aware that John was tying the child to the bed to prevent the child from getting out of the bed. Jane also reported that John will poke at her son's skinned knee as a form of punishment. Verified and substantiated findings of medical neglect were also indicated. According to the family functioning assessment, the child was seen in the emergency room for an unexplained physical injury to the child's wrist. Based on information provided, John was aware that the child had broken his wrist and failed to seek medical attention until 2 days following the actual incident. According to Jane, she was at work when the incident occurred and reports that John had indicated that her son fell down while playing. The family functioning assessment indicates that John used wood and a military ace bandage to splint the child's wrist. John and Jane have a documented history with the Department of Children and Families to include verified findings of substance use. During the course of this investigation, both parents submitted UAs which indicated positive results. Results of Jane's UA indicate that Jane was positive for marijuana, opiates, amphetamines, and methamphetamines. Results of John's UA indicate that John tested positive for marijuana, opioids, amphetamines, methamphetamines, and benzodiazepines. Jane was involved with the Department of Children and Families as a minor and was removed from the care of her biological mother and stepfather at the age of 8 years old due to her parents' substance use and domestic violence. Jane was never reunified with her biological mother and was placed in the care of her maternal grandparents. As an adult, Jane has been investigated by the Department of Children and Families on several occasions to include allegations of substance use, environmental hazards, medical neglect, and inadequate supervision. John also has a history of family violence involving his ex-paramour and his biological son. Review of Fitspin indicates that John has a no-contact order with his biological son and ex-paramour. John has a history of interactions with the legal system to include incarceration for drug-related arrests and arrests associated with violence. Specifically, John has a history of violent arrests to include assault, battery, domestic violence, and assault with a deadly weapon. As mentioned previously, during the investigation, both parents were positive for substances. Based on information provided, the child was placed in protective custody. Jane has supervised visits with her son, and a no-contact order has been placed between John and the child. As a result, John has no visitation privileges with the child and has indicated that he is not willing or wanting to complete a case plan. So the case that I just shared with you, it's a very tough case, and it has likely provoked some pretty serious reactions or emotions. With that being said, I think that it's very important that when you're assessing trauma, when you're assessing substance use, in situations where you're going to be involved with individuals that are involved with child abuse and neglect, it's important to be aware of counter-transference issues, being aware of your own beliefs and feelings. So case file information, kind of like what I just shared with you, reviewing that case file information and the information or the details about the woman's involvement with child welfare, it can be very, very difficult to read. You may experience feelings of anger, helplessness, you may feel sadness, but with that being said, it's important to be aware of those feelings and your own emotional responses. My suggestion is seeking out clinical supervision and guidance from another clinician who is seasoned and has experience working with that population. Again, I really want to focus on in examining and being involved with cases that were similar to the case that I just discussed. I cannot stress I cannot stress the importance of understanding and recognizing your own feelings and your own thoughts and your own responses as a therapist. With that in mind, just again, be aware of counter-transference issues. Luckily for me, I had a well-trained and a very seasoned therapist who was the previous family care assessor. So with her as my support, I was able to process and better understand my own emotions and my own reactions to cases that were, extremely difficult. So again, failure to address or examine your own personal baggage or feelings can be detrimental to the women you assess. If we are not adequately prepared to examine ourselves and our own perceptions, what we notice about the presenting problem can be skewed, inaccurate, or avoided completely. Assessing and exploring trauma are difficult. Some clinicians are not equipped or trained to do this, and I want to start by saying that is okay. As therapists, we have our strengths and we have our weaknesses, and we need to be able to recognize both. So during the assessment, establishing rapport and building trust, that's kind of my initial goal within the first 15 to 20 minutes of the interview, is to establish that and create an atmosphere to where the client feels safe and there's a feeling of mutual respect. So typically, what I do is I introduce myself and explain my role as the family care assessor. I also explain limits of confidentiality, especially as it relates to child abuse. I also explain the purpose of the evaluation, and I say that the information that we discuss, I really stress to the client that the information that we discuss may be difficult for the individual. And so what I've done is I've provided an example kind of how I would, kind of what my first interaction with the individual would look like. So, here's the example is, welcome to Chautauqua Healthcare Services. We are so glad that you are here. We look forward to exploring how we can best help you and your family. I'm Amy Falin, the family care assessor. To begin, we are going to work with you to consider treatment options and develop goals to meet your needs. The family care assessment is an in-depth mental health and substance abuse evaluation. You are referred by Jane Doe, Child Protective Investigator, to address concerns surrounding your current involvement with DCF. We are going to talk about some of that today, but this assessment is mostly about you and helping you to be the best parent that you can be. Although some of the information that we discussed today may be difficult for you, I want to reassure you that you are safe. If at any point you feel overwhelmed or nervous, please let me know. Feeling nervous or overwhelmed during this interview is okay, so please let me know. If you have questions or concerns about the information that I'm asking you, or the information that we are discussing, please let me know, and I will try my best to assist you. Do you have any questions or concerns so far? I understand that prior to meeting with me, you completed releases of information for DCF, FFN, WISE, Shelter House, and Guardian Ad Litem. These are limited releases of information. However, they allow me to communicate specific information to these agencies. For instance, I will disclose that you completed this assessment and the treatment recommendations. During treatment, this allows the provider to communicate your treatment progress and attendance to your caseworker. As a general rule, I make my best effort to limit the details of what we discuss. If at any point you feel uncomfortable about sharing specific types of information, please let me know. With this in mind, I want to reassure you that you are protected by HIPAA and confidentiality laws. However, there are several limits to confidentiality that I must discuss with you before we can begin. If you report child abuse or neglect of a child or a vulnerable adult, or if there is suspicion of child abuse and neglect, that information must be reported and is mandated by law. Second limit to confidentiality is if there is a clear and immediate probability or threat of physical harm to yourself or others. I have a duty to protect and to ensure your safety and the safety of others. Do you have any questions about confidentiality? So, and then something else that I typically do, and you can see how when I was introducing myself, how I continued to kind of reassure, how I continue to reassure the woman by letting her know that if at any point she had questions or concerns, for her to let me know. If she needed a break, to let me know. So providing that additional reassurance to the woman, I have found it has been very effective in establishing rapport and getting in developing that therapeutic relationship with the individual. Something else I do is right before I go into the assessment, I ask the woman, what are you going to do if you have questions or you feel overwhelmed during this interview? I want to make sure that it's clear that she can communicate to me that she's feeling overwhelmed or that she needs a break or she has questions or concerns. So again, as mentioned previously, this method does appear to reduce some initial feelings of anxiety that the woman may have experienced. It also communicates some degree of reassurance and collaboration with the woman. It lets her know that feeling overwhelmed or nervous is okay, and that I'm trying to let her feel in control of what she chooses to disclose. So identifying strengths and abilities. Okay, so identifying strengths and abilities. One thing that may be different, or what I feel is different than what other clinicians do, is I try identifying strengths and abilities of the client at the very beginning of the interview, rather than going straight into the problem. Why do I do this? First of all, it kind of catches the woman, it catches her off guard, but it is extremely helpful in establishing rapport with her and building trust. It kind of takes the whole atmosphere and the whole assessment in a different direction by becoming more strength-based and solution-focused rather than problem-focused. So here are some examples of questions that I use to identify strengths. For instance, what are some things that you are good at? I may start off by asking her that, or what would you consider to be some of your personal strengths? Can you tell me about times in your life when things were going really well for you? What do you think that you were doing to make those things well in your life? What are some challenges that you have faced in your life, and how have you been able to overcome those challenges in the past? So sometimes what you'll find is that for some women, identifying their personal strengths is very, very difficult, especially when they have identified their strengths as being a caregiver or a mother. This sense of self may make her feel lost. This sense of self may feel lost to her when her children have been removed. Also, identifying strengths also assists me as the clinician in examining how the woman views or perceives herself. It gives me insight into her own perception of her self-esteem and her self-worth. In cases where the woman has difficulty identifying her strengths, I actually have a list of strengths that are kept within my reach during the assessment that I will use as a tool for the woman to review different strengths, especially when she is having difficulty in identifying strengths. As she begins identifying strengths, I begin a conversation with her about the specific strengths that she selected or she chose, and how she has used these strengths in the past and how she uses them now or in the future, or how she can use them in the future. So right after discussing the strengths of the individual, this may be a good opportunity. I think it's more or less, as a clinician, you'll have to determine when it's a good idea to actually go into the presenting problem. But again, what I typically try to do is I go in, focus on the strengths first, and then I go into the presenting problem or evaluating the presenting problem. Some questions when I'm evaluating the presenting problem that I ask is what brought you here today? Or how did you become involved with DCF? What do you hope to accomplish today? How do you feel about treatment? What type of treatment are you interested in receiving? What do you think that you would benefit from? So those are all those are examples of questions that I ask after exploring strengths and trying to get into or begin exploring the presenting problem. Okay, so during the assessment, one of the key things that I want to discuss is evaluating substance abuse. I'm going to suggest identifying the substances that the individual has currently or recently used, identify the age of initiation, method of ingestion, typical consumption amount, frequency of use, and date of last use. And that is also a guideline or a recommendation made by SANSA 2015. And also, I want to reiterate that when you're conducting assessments, especially when you're looking at substance use, I think that it's very, very important that you're having a conversation, an actual one-on-one conversation with the individual that you're providing services to. This approach is helpful when gathering information, and it continues to build rapport and establishes trust with the woman. When asking these questions, when I'm asking questions, I try to avoid asking it in kind of a checklist approach, but I look at it as having an actual, one-on-one conversation with the client. So some women may choose to deny any recent or current substance use or involvement during the assessment. So what I typically do is that I will begin discussing with her, UA results, concerns that were reported or presented by the referral source. I try to stick to the facts when I'm discussing, substance use, and the client is or not the client, but the woman isn't acknowledging the substance use. I try to present to the facts, and I do that in a way that's non-confrontational. If she continues to deny substance use, I always discuss some of the goals, of the case plan and why DCF is involved. I try to avoid confrontation at all costs, as it often leads to increased defensiveness and kind of shuts the individual down. And then also something else to remember is that ambivalence towards substance use and change in general is normal. So when the individual may not be discussing the full extent or nature or severity of their substance use, I understand that this is normal and that it may be part of the process. But again, when there's a lot of minimization and denial associated with the substance use, that's another reason why I choose to use kind of a conversational style approach, and that's another reason why I believe that that is important.
Amy, hi, it's Leanne. Listen, is it going to be convenient to take a break, a 5-minute break for the group at this point or soon?
Yeah, that's fine. If you guys want to go ahead and do that, we can do that.
Is it a good time for you if we do that now?
Yeah.
Okay, wonderful. So let me just let everyone know who's attending today. We are going to take a break at this point. We like to take a 5-minute break, so we will come back at 2:10 sharp. So we'll resume at 2:10. Thanks very much. And Amy, I'm going to shoot over a message to you in the chat box, okay?
Okay, awesome.
Thank you. Hello, everyone, and welcome back. This is Leanne. And Amy, if you're ready, I think we can proceed.
Okay, thank you, Leanne. Okay, so something else that I want everyone to remember is that the assessment is an ongoing process that will extend into treatment. So even though the individual may not share the full extent or involvement with her substances during the actual assessment, she may end up disclosing more during treatment. Therefore, just remember that the assessment is an ongoing process that extends into treatment. Also, in evaluating substance use, it is important to screen for withdrawal symptoms. Such symptoms experienced during pregnancy may place the client at risk. For instance, opioid withdrawal during pregnancy brings significant medical risks, including premature labor and fetal mortality. As a result, pregnant women should always consult with a physician when deciding to discontinue using substances. I also want to point out that it is the clinician's responsibility to refer, follow up, and work with the physician or the OBGYN who is providing services to the woman. What I would always do is I would get a release of information to the individual's OBGYN and send information that way. Also, something else that is important to look at. So opioids, sedatives, hypnotics, benzodiazepines, and severe chronic use of alcohol are more likely to require intervention for detoxification. Attempt to identify who first introduced drugs and alcohol. I'm sorry, let me rephrase that. So attempt to identify who first introduced her or the woman that you're interviewing to drugs and alcohol. Reason for her first use or initiation of use, and reasons for continued use. This provides useful information about her relationships and the nature of her relationships. Discuss significant relationships and romantic relationships, and ask how substance use occurs within the dynamic of that relationship. And then something else to be aware of is that when you're looking at substances that may require detoxification, be very familiar with the community and the resources that are available within your community in regards to medical treatment and detoxification, especially for individuals who may lack financial resources and or insurance. Also consider using case management services if the woman is not currently involved with case management. So here's a sample of a format that I use, and again, I want to reiterate that when you're looking at substance use, do it in a conversational style format. This is something that not only do I put like the summary of what when I'm doing the actual report, I do a summary of kind of what's discussed about the substance use, but this right here is kind of is a way that you can format it in addition to the summary that is provided. Also, evaluate and assess the client through actively engaging the client in a conversation. Again, I've stated that several times. Avoid just asking assessment questions or checking off boxes. My best what I would suggest is being an active observer and let the woman tell her story, or let the women tell their stories. So I'm not going to read, so here is a case example or case illustration. I'm not going to read the actual information. I'm just going to go through some of the questions that I asked during the substance abuse portion of the evaluation. You guys can read the actual information that was gathered regarding the actual case. So one of the things that I would ask is, or how we kind of start off discussing substance use would be, so tell me about your first experience with drugs. After using cocaine for the first time, how would you describe your pattern or involvement with substance use? Recently, what substance have you used or been involved with? So this right here, this just indicates kind of a summary of what the client disclosed when I was interviewing or engaging in a conversation with her. Sarah reported making several attempts to discontinue her use of amphetamine type or amphetamine-related substances, but she was unsuccessful in doing so. She says that her longest amount of dry time was 2 years. She denied ever receiving any type of substance abuse services, and she also acknowledged a significant family history of substance use and said that beginning in early childhood, she was exposed to and involved with substances. So evaluating behavioral health or mental health history based on information provided through SAMHSA 2015, all women entering substance abuse treatment should be screened for co-occurring disorders. Because symptoms of withdrawal and intoxication may mimic or exacerbate symptoms associated with mental health disorders, the assessment of co-occurring disorders should be an ongoing process. So I have a whole list of questions that I was going to discuss. However, for time purposes, I'm not going to go into that entire list. But here's some general questions that you can discuss when evaluating mental health. Ask questions about past or present mental health symptoms and diagnoses. Ask about duration of symptoms, whether the symptoms are persisting, and also inquire about treatment history. So here is this is a case illustration, and again, I'm not going to read through the actual illustration that I provided, but I am going to kind of go through what some of the questions that I asked, what those questions were. So, have you ever received psychiatric or mental health treatment for symptoms? What were you treated for? What type of treatment did you engage in? And again, avoid, as I've mentioned before, avoid doing it in a kind of a checklist approach. Make sure that you're actually engaging in a conversation with the client. So what does anxiety look or feel like? What type of thoughts do you experience that are anxiety-provoking? How do you experience these symptoms? And how do you currently manage or cope with symptoms? So we're going to kind of jump into evaluating trauma specifically. First of all, trauma-informed means being aware of the past and present abuse or trauma that women have experienced over the course of their lifetime. We need to be able to assess trauma, monitor it, and know about the significant impact the trauma has on the lives of the women that we serve. Okay, so when evaluating trauma, you may want to start with using a brief screening questions to determine whether women have experienced or been exposed to any traumatic events. This is also consistent with recommendations made through SAMHSA 2015 about evaluating and examining trauma in women. In evaluating trauma, it is important to begin the process, or what I do is I try to start the process in a very slow, general, and gradual manner. I want to avoid overwhelming the woman in the interview or the assessment process, because that can be dangerous and may result in her feeling extremely overwhelmed or as if the event were reoccurring. But you also do not want to encourage or reinforce avoidance associated with discussing trauma-related events. Women may be at risk for disclosing too much too soon, so this is something else that you have to look at when you're evaluating trauma. And disclosing too much too soon, this could be a result of her feeling guilt, shame, and this could result in her feeling guilt, shame, and embarrassment after leaving the interview. Before women disclose too much information or they start really kind of discussing some of the details, you want them to have adequate coping skills, safe behaviors, and trusting relationships in place. Therefore, pacing and timing are necessary and needed. So my aim when I'm evaluating trauma or when I'm looking at trauma, my aim is not to collect all the details of the traumatic events or for the women to present all the details of the traumatic events during the assessment. My goal is to screen for traumatic events, determine whether PTSD or trauma-related symptoms or events are present, and I also want the woman to feel like she has control over what she is disclosing. So why is this important? Disclosing too much too soon or forcing the woman to disclose may provoke intense emotional reactions or responses that cannot be adequately or appropriately addressed within the context of the assessment. And again, although exposure-based therapies are considered the gold standard for treating PTSD disorder, you have to remember that this is the assessment, and I'm not going to be able to process the trauma with her during the actual process and kind of release some of those intense feelings that she may experience when discussing that. Also, few if any studies have examined exposure-based therapies among individuals with both substance use and PTSD. So women with substance use disorders or in the early stages of the recovery process may not have the resources or coping skills to adequately or safely cope with the intense emotional responses that are often experienced when disclosing details of traumatic events. Therefore, it is extremely important to begin the process in a slow, general manner. Okay, so here are some of the screening questions that I ask. Have you ever experienced, witnessed, or been exposed to any of these following? Child physical abuse, child sexual abuse, child neglect, domestic violence, or abusive events or relationships as an adult, or sexual violence such as rape. Have you ever experienced, witnessed, or been exposed to events or situations in which you felt your life or someone else's life was in danger? Have you ever experienced, witnessed, or been exposed to any other events or situations in which you have felt horror or extreme fear? So when you're asking these questions, they're yes or no questions, and typically I gear away from asking just yes or no questions except when I'm evaluating trauma during the actual assessment. So when I am evaluating trauma and I'm asking these kind of yes and no questions, I'm also monitoring her response. If at any point I begin to notice a change in her affect, or if she appears to become upset, I try to redirect the questions and provide support and reassurance to her. According to SAMHSA 2015, brief screening is important because it establishes past or present traumatic events and begins identification of PTSD-related symptoms. So during the assessment, you may not be able to gather all the information needed to make a conclusive PTSD diagnosis, but you have gathered some basic information that can be further explored and examined during treatment. So you may not have the individual may not meet full threshold for a PTSD-related disorder, but you do have some general information of some of the experience that the individual has experienced throughout their life. And also, I've mentioned this several times, remember that the assessment is always ongoing and that the treatment plan can always be changed to meet the woman's needs. Also consider how and when the questions are asked during the interview. I usually ask the questions, especially as it relates to trauma, I usually do that before I begin exploring family of origin or family history and those relationships. Also, I may continue gathering information related to trauma as I am examining and exploring the family of origin and family of history. For instance, I've had clients I've had clients, say that no, that they haven't been exposed or they haven't experienced any traumatic events when assessing for trauma. However, as I begin exploring family history, kind of some of the events that occurred in the client's life, there was evidence of some pretty significant exposure to trauma and some traumatic events. So, keep that in mind that as you're exploring, family of origin and family history, that some of those trauma events may come up. So, as mentioned previously, research reported, we're going to talk about evaluating trauma and sexual abuse among women. As mentioned previously, research reported by SAMHSA found high rates of sexual abuse among women entering treatment for substance abuse. Many women may be reluctant or unwilling to disclose past histories of sexual abuse at screening or intake. This may be related to their perception of normal. Prior to treatment, the individual may not have perceived their relationships as abusive. The perception of normal also varies fairly significant when you're examining family history and trauma. Individuals that have been exposed to multiple traumas or grew up in dangerous environments, they may perceive the events that have occurred, sometimes atrocities that have occurred in their life, they may perceive this as normal. Therefore, kind of follow up with kind of getting an understanding of what the client's normal looks like. So a woman's exposure to childhood sexual abuse and other traumatic events may need to be explored further during the treatment process after the woman has established trust with her therapist. This further supports the importance of an ongoing assessment even into treatment. So evaluating family. Although the role of the family may serve as a protective factor among women with substance abuse problems, drug use within the context of the family of origin may serve as a risk factor associated with the development of substance abuse and or dependence among women. Family relationships in childhood serve as models for women's future relationships. Adult relationships of women with substance use problems may model what they experienced as children. Thus, it is important to examine both the family of origin and current partner relationships as they relate to the woman's family and her children. So, questions to assess a woman's family relationships and the role of her extended family. These are some of the questions that I may ask. So while growing up, how would you describe your family? Who raised you or whom did you identify as your primary caregiver? If a client states that they had a normal childhood, I always follow up and ask, so what do you mean by a normal childhood? Or how was your childhood normal? Here are some additional questions that I ask when I'm examining family. So tell me about your siblings and your relationships with your siblings during your childhood. What were some strengths of your family? What were some of the challenges within your family? Was DCF ever involved with your family during your childhood? Did you ever witness or were you ever exposed to abuse or neglect within the context of your family? Did you ever witness abuse or neglect within the context of the family? Did you ever witness your parents or caregivers verbally or physically, fighting while you were growing up? And then I kind of transition as to where's that client's family of origin now? Does the client still have a relationship with their family of origin? So I kind of start that off by asking, does your family still reside in the local area? What is your relationship like with your parents and caregivers now? So where and when did you feel safe while you were growing up? What about the relationship that you have with your siblings now? So questions to assess the client's family relationships and the role of the extended family. Again, this is when I kind of start looking at their relationships with their partners, their boyfriends, their paramours, their significant others. So I may begin by asking, so tell me a little bit about your relationship with your current partner or your husband. How long have you been married, or how long have you been in a relationship with your current partner? How would you describe your relationship with your current partner? Have you ever used substances with your current partner, or been in a relationship in the past in which you used substances with your partner? How often do you typically stay in a relationship with a partner? So when I'm asking the client to describe their relationship with their current partner, and the client states that the relationship is good, with little to no detail in their response, I always try to follow up asking, so what is good about the relationship? Or ask them, how would you describe, how would you describe a bad relationship? Or have you ever been in an unhealthy relationship before? I also ask, have you or your partner ever become physically violent towards one another? How would you describe your current interactions with your partner? What are some strengths within your relationship with your partner? What are some challenges or barriers that you and your partner experience together, and how have you dealt with or overcome those challenges or barriers in the past? So understanding the nature of the woman's current and past relationships is important in understanding the interaction between her substance use and involvement with substances. Family relationships are characterized by substance use, or in which substance use is or was a central theme or dynamic, may reinforce and enable the client's, or the woman's continued use and abuse of substances. So as mentioned previously, women are more likely to be introduced to drugs and alcohol through partners, spouses, and family members. Additionally, women are also more likely to have partners who use substances. According to Najavides, women have a tendency to model the addiction patterns of their significant others. In families in which substance use and abuse or neglect were not common themes, the family could be used as a strength and a protective factor for the woman who is being treated. Improved substance abuse outcomes have been found among women with strong social support systems. So in evaluating pregnant women, in assessing and evaluating pregnant women, special attention and care should be given. Routine drug and alcohol screening for pregnant women is recommended. It is recommended that clinicians provide care coordination with primary care physicians, OB and GYN healthcare providers, etc. SAMHSA also indicates that face-to-face interviewing is not always successful in evaluating pregnant women's substance use patterns. SAMHSA has suggested using the TWEAK questionnaire, the TH questionnaire, and the prenatal substance abuse screen. I'm going to skip over this due to time. So another important thing to evaluate is evaluating parenting and parenting roles. A history of child abuse and trauma can result in parenting problems. Parenting with substance use disorders often use inconsistent child-rearing practices. SAMHSA suggests evaluating safety concerns during the assessment phase. These are some questions. These are some questions that I use and that have also been recommended by SAMHSA. What are the child safety issues that currently or recently investigated by DCF? Is there a history of similar investigations or involvement with DCF? During the assessment, explore the various past and present caregiver roles that the woman has played. Was she involved as a caregiver for her siblings? Is she caring for her spouse or significant other's children? Is she caring for aging family members? And most importantly, ask about parenting strengths. So, for instance, this is one way I may go about talking about parenting strengths. So you talk a lot about your love for being a mom. What is it about being a mom that you love? As a mother, can you tell me or can you identify what your parental strengths are? I also evaluate for parenting challenges. For instance, what are some of the greatest challenges that you have faced as a parent? How did you overcome these challenges? Okay. So objective 3 is how to use the assessment to develop and establish treatment plans and treatments that effectively address the stresses, traumas, and goals of parenting and pregnant women who abuse substances. So first of all, identifying and overcoming treatment barriers. This is something else that during the assessment I do assess for possible treatment barriers, what could prevent or what could possibly prevent her from getting treatment. So women are faced with a number of interpersonal, both individual and relational factors that serve as potential barriers associated with treatment. A number of these barriers were discussed during the introduction to include the women's roles as caregivers, the impact of social relationships, and fear and guilt that is often associated with substance use. Other barriers that have been identified include structural or programmatic barriers. For instance, residential programs do not typically allow mothers to bring their children. Outpatient programs rarely offer child care services when the service is being offered. Sociocultural barriers, women are often fearful that they will be perceived as bad mothers. And then systematic issues, such as lack of transportation to and from treatment, or fear of the legal consequences associated with disclosing substance use and/or substance use problems. Barriers can be, as I mentioned before, barriers can be identified during the assessment process, or identification of these barriers may not occur until the client begins treatment. So to overcome challenges and barriers and to improve treatment outcomes, identifying effective treatment engagement strategies is important. So SAMHSA has suggested several, one of them being outreach services, comprehensive case management services, and pre-treatment intervention groups. And also I want to reiterate again that multidisciplinary team approach. Part of assisting the woman in overcoming challenges and barriers is using that multidisciplinary team approach. Each member of that team brings a unique service to the team, and most importantly, it brings a service to the woman. So again, outreach, case management, and pre-treatment intervention groups are 3 of the engagement strategies suggested by SAMHSA. So outreach services, they assist women in identifying their most important needs, navigating and negotiating the human services or child welfare system, understanding their own resistances, and making and following through with commitments. This may include linking the woman to child care services and identifying transportation resources that can help women to follow through with commitments and/or appointments. So outreach services may include, for instance, outreach services that could include assisting the person served in identifying transportation resources, child care, employment, or housing. Pre-treatment intervention groups often function as an additional resource for women. Such groups provide information about treatment options and also provide personalized feedback about substance use. Pre-treatment intervention groups are often helpful in addressing and overcome psychosocial barriers, such as stigmas related to substance use. Depending on the needs of the women that are served, the intervention groups may be gender-specific or trauma-based. So pre-treatment intervention groups may consist of services such as women-only groups, NA or AA meetings, pregnancy support groups, peer support groups, or parenting support groups. Pre-treatment intervention can be used in conjunction with case management and outreach services as a way to establish a support system and motivate women towards behavioral change. So increased social support may reduce some of the stigmas and foster hope for the client. Such support also can increase women's opportunities for additional linkages to support services. Although the individual, she may not be fully ready or able to commit to treatment, but providing her with alternative options and support, such as pre-treatment intervention groups, and other supports such as case management that may motivate her towards behavioral change and treatment. Comprehensive case management services, they typically provide an array of services to women to include outreach, advocacy, identification, and available resources, linkages to services, and treatment monitoring. I cannot stress enough the importance of comprehensive substance abuse case management services. I have been very, very lucky to work with a case manager that is awesome. She is able to focus more directly on outreach, advocacy, and linkages, and it's a partnership. So I've been very lucky in working with an awesome case manager. So if you ever have that opportunity, I would suggest trying to collaborate. Because again, and that kind of goes back to, modeling behavior, relationships, and social connections to others are important factors that have to be considered when addressing and treating substance use issues among women. So treatment may need to address the negative impacts that important social relationships have had on women. One treatment approach may involve communication training, stress management, assertive skills training, and problem solving. Women who work towards mastering these skills may see overall improvements in their ability to initiate and maintain adaptive, healthy social relationships. As women progress through treatment, the aim is that they will begin to develop appropriate relationships with others and will be able to reevaluate and replace negative, harmful relationships with healthy, adaptive relationships. So partner relationships are additional issues that will occur and come up during the course of treatment. In deciding to work with a woman and her partner, consider the safety risk and the partner's actual willingness to engage in treatment. If at any point the woman determines that the relationship is unsafe, services should not be offered. Because of the inconsistent parenting practices that are often associated with substance use, women involved with substance abuse treatment may benefit from treatments that address the parent-child relationship and help her to fully engage with the child. SAMHSA 2015 indicates that while the mother is learning how to parent, her children often need help in overcoming the effects of parental substance use. Also, referrals to community-based parenting programs are often not enough to address the needs of children. So children may also be in need of treatment or additional support services to further address the mother's behavior, as it has likely impacted the overall dynamics of the parent-child relationship. Also, when looking at specific treatments for children, consider play and expressive therapies that will help children acknowledging and expressing their feelings. Assessment and screening for developmental and learning delays, as well as possible social problems, may be necessary for the children that are affected. Okay. So trauma-informed parenting, so what is that? This assists mothers in identifying triggers, learning and developing appropriate healthy boundaries and discipline, and learning nurturing behaviors for effective parenting. So here are some trauma-related clinical issues. One of those being psychoeducation, which is educating women about the connection between substance abuse and trauma. Psychoeducation can actually begin during the assessment phase of treatment. For instance, once a woman discloses to me exposure or experiencing some type of trauma, I typically try to educate her about the relationship between substance use and trauma. And this process of psychoeducation and educating the client about symptoms should continue throughout the course of treatment. Normalizing symptoms is another trauma-related clinical issue, and that involves educating and discussing symptoms with women to normalize the psychological and physiological experiences that they may be experiencing. Normalizing symptoms oftentimes, or what I found, it oftentimes provides hope and understanding, kind of what's associated with they get an understanding of kind of what they've experienced as it relates to trauma-related symptoms. So safety, support, and collaboration. Developing a therapeutic alliance through creating a safe place where women can begin to learn to trust again. Monitoring levels of distress while the individual is in treatment. Counselors need to be able to monitor their own levels of distress, which we talked about earlier, as well as the stress levels of the women they serve. You also need to monitor, like if it's in a group setting, kind of monitor the group for levels of distress as to kind of what's going on. Just be aware of that. So timing and pacing with trauma, issues are addressed when a woman is ready to address trauma and when she is functioning at a level where exploration of trauma is safe. The therapist's role is to assist the woman in identifying when she is becoming overwhelmed and how to slow down that process. So coping skills. In order to increase self-sufficiency and self-efficacy, women need to learn and utilize coping skills to manage their symptoms. The therapist's role is to include skill development in areas such as effective communication skills, anxiety management, and stress reduction. Triggering and traumatization. Triggering is unavoidable as it relates to trauma. The therapist and the women they serve must work together in identifying and coping with triggers and identifying what those triggers are. So I've identified 3 evidence-based treatment programs or curriculum that treat both substance use and PTSD simultaneously. They treat them together. The first one that we're going to talk about is Seeking Safety. So Seeking Safety is based on 5 principles. With safety, safety is always priority. It's integrated treatment to address both PTSD and substance abuse. During treatment, there is a focus on ideals, which is honesty, combat denial, lying, and false self. 4 content areas: cognitive, behavioral, interpersonal, and case management. And then attention to the therapeutic process. With Seeking Safety, there's 25 different sessions that can be available, and they can be broken down to include multiple sessions per the 25 sessions. But something that I want to touch base on is the attention to therapeutic processes. The therapeutic processes emphasize the importance of building a therapeutic alliance, having compassion for the women, and using coping skills. So using those coping skills in one's own life and giving the client control whenever possible, and modeling what it means through meeting the client more than halfway. Also getting feedback from the client. Those are some of the therapeutic processes that are involved. So Helping Women Recover, a program for treating addiction. This integrates multiple theoretical models, theory of addiction, theory of psychological development of women, and theory of trauma. It is a gender-responsive treatment with a focus on 4 areas: self, relationships, sexuality, and spirituality. The program includes a facilitator's guide to address issues of self-esteem, sexism, support system, mothering, self-soothing, and family of origin. And it has 17 sessions. Beyond Trauma, a healing journey for women Beyond Trauma, a healing journey for women. in a healing journey, a workbook for women. So this specific treatment is designed to address the traumas that are prevalent among women, including a psychoeducational component, teaching women about trauma and the impact that trauma has on thoughts, feelings, beliefs, and behaviors. Relationships, it also emphasizes the impact that trauma has on relationships to include parenting. The program focuses on the development of coping skills, cognitive behavioral strategies, and expressive arts. There is a facilitator's manual, client workbook, and videos available. So, do we have any questions thus far?
Hi, Amy. Yes, we do have a couple of questions. Are you ready for them?
Yes.
Okay. The first question, this came in fairly early in the presentation. It was around slide 28, something like that. And the question is the family care assessment the same as the family-centered care assessment?
Okay, so I'm not really familiar with what the family-centered care assessment is. Is that something that is used in another circuit?
And I don't know the answer to that question, Amy. I'm sorry.
Okay.
And it may be if the person who asked that question wants to clarify, they can. And while we're waiting for that, let me go to the next question.
Okay.
So this next question, it looks like it's sort of a two-part question. So and it's lengthy, so what I thought I would do is read through both questions and then come back to the first one, if that's all right.
Yes.
Okay, so I'll read through both of them first. And this was around slide 55. It was right when we came back after the break.
Okay.
Okay, so regarding confidentiality when working with a DCF client, is there a disclosure form that licensed clinicians have to sign with DCF that would require the clinician to disclose any and all information the client conveys during the assessment and treatment? That's question one. If so, how does the clinician guarantee a safe, secure, and trusted relationship with the client if the client knows up front that the information is shared, that the information they share during treatment will need to be given to DCF? All right, so let me go back to the first part of that if you're ready.
Okay.
Okay, so regarding confidentiality when working with a DCF client, is there a disclosure form that licensed clinicians have to sign with DCF that would require the clinician to disclose any and all information the client conveys during the assessment and treatment?
Okay, so in regards to this disclosure, I know that what we have done is we do a release of information between DCF and the client. It's very, and I don't know if I'm answering the question correctly, but I know that the information that is given to DCF in regards to treatment is very, very vague, if that makes any sense. Meaning that I know that we do treatment dates, like the days that they actually attended treatment. We don't necessarily give details about actual treatment, if that makes any sense, like specific things. Okay, so then to your knowledge, you're not aware of a specific disclosure form that clinicians have to sign with DCF that requires them to disclose any and all information the client conveys? Not that I'm aware of, no. Now, I will say this, our agency, we do have a disclosure form. We have a disclosure form that the client signs, you know, acknowledging that certain types of information may be disclosed.
Okay, gotcha. And let me see if I can communicate this one. Actually, we have two more, it looks like. This says, where can we get a copy of the family care assessment? I looked it up online and only found a family-centered care assessment. So again, it's related to that family care assessment. Where can they get a copy of the family care assessment?
I'm not sure that like an actual, that was a model that was used in Circuit 1, that we used in Circuit 1. It's not an actual, there's not like an actual hard document regarding it.
Okay, all right, thank you for that. And let me see if there's anything else. And again, I'm not sure if I'm going to read this correctly, Amy, so let's just see. The person says, we also prefer the 2 interventions you recommended versus EMDR. Can you give me a brief reason why you also chose the 2 in this presentation, if you have time?
Yes. Okay. So with the interventions that I selected for this specific presentation was because of first of all, it treated both substance abuse and it treats substance abuse and PTSD simultaneously. It treats them together. In terms of exposure-based therapies, is that what the question is?
Yes.
Okay, so I chose that because those 2 interventions are more present-focused, to whereas individuals who have substance use disorders and PTSD-related symptoms, that can sometimes be a little tricky when you're doing exposure-based interventions. Not that exposure-based interventions, they're great. Don't get me wrong, they're great. But when you're doing substance use and exposure-based interventions, that may be too overwhelming and could possibly, my concern is that it could possibly trigger a relapse or some form of dangerous behavior. So what I always try to do if an exposure-based intervention is going to be used, first of all, I think that the client should be educated about different treatment options first. And if that's something that individual client feels like they would benefit from, then that's something that individual can choose to do. But in terms of actually, for me, choosing those 2 interventions is, number one, is because it reiterates the importance of safety, and it also treats both the substance use and the PTSD at the same time.
Wonderful. Okay. And Amy, that concludes the questions. I think we've been able to address them, and you've done a great job bringing all that information in for landing on time, so well done. If you're ready, I'll go ahead and wrap it up for the group. If you're ready, I'll take control back.
Yes, ma'am.
Wonderful. So again, Amy, thank you so much for spending time with us today and giving us the benefit of your experience and expertise. We really appreciate it, and tackling the questions that came in. And I also want to thank, of course, all of the participants who attended today's webinar. We always appreciate your interest and participation. And many of you already know this, but do be aware, when I close the event and we all exit the webinar, your browser is going to take you over to the evaluation form on the FATA website, and you can go ahead and complete your evaluation. It doesn't take very long. However, if something happens and you get interrupted or you don't get forwarded as we would expect you to, that's okay. You're going to get a second opportunity to complete the evaluation through a follow-up email that will come to you later today. So do remember, if you want to receive CEUs or certificate of attendance, to complete the evaluation. And again, the certificate of attendance and a copy of the presentation in a PDF format is going to be sent out to all of the attendees within 5 business days. And that wraps up our comments there. And of course, in conclusion, we also want to make sure and thank the Florida Department of Children and Families, the Office of Substance Abuse and Mental Health for funding for today's presentation. So again, Amy, thanks so much, and everyone have a great rest of your day, and please hold for the evaluation. Thank you.